taking a look outside the window. I'm hoping everybody survived shoveling this morning, didn't slip on the ice. But I'm going to talk about an additional hazard that we have at this time of the year, being the respiratory viruses, and in specifics, RSV, COVID, and influenza. And I'm going to just put up disclosures. Any relevant financial relationships have been mitigated, and given that there was no mitigation done, I don't think there are any significant financial relationships here at all. But when we talk about the hazards, I'm going back to the American Lung Association and talking about COVID, flu, and RSV. And these are three things that we have immunizations for. And what I'm going to try and do in this talk is provide an update of a lot of the literature that's come out in the last several months here to fill you in on what's going on. So the objectives today are, number one, just to appreciate the continued profound clinical impacts of RSV, COVID, and influenza. Describe the current states of RSV, SARS-CoV-2, and influenza across Wisconsin and the US, and then apply recommendations for prevention, recognition, diagnosing, and treating these three. And then I'd like to finish up talking about some of the systems out there for respiratory virus situational awareness. So profound effects right now. We were just talking before we started on the effects of COVID-19 on clinical practice. And I just really want to emphasize the role of viral diagnostics, the non-pharmaceutical interventions such as distancing and masking, and mRNA vaccines, all that really emerged during this pandemic. I had the slide last year, but I like it very much. Just consider the fact that by a year into the pandemic, the number of PCR tests done for COVID in the United States exceeded the entire population. We have never applied PCR as widely as we did during the pandemic. And consequently, we also found the emergence of a lot of rapid testing. So if I were able to ask and have people show their hands, I would think that almost everybody in the audience has done at least one rapid test for COVID on themselves. This has become ubiquitous, and we're seeing the emergence of a lot of other viral pathogens in the rapid test arena right now. I love this slide. This is a paper that we just published. It was Cecilia He who was the main author. But I really want to draw your attention to the black line here. And the black line represents the percent of households in a community, this is in Oregon, Wisconsin, with a new ARI. And I want to point out that at first we have what I would call kind of a normal winter scene. And then we get into a low period through the pandemic. In 21-22 school year, we get kind of back into some activity. And by 22-23, we're back to normal. But I'll give an overlay here. With school closure, we had a profound reduction in ARI. During that first summer, actually kids transmitted more, and we saw an increase. When children, however, came back to school in 2020, 2021, there was no increase. And this was the effect of masking and distancing and hybrid education. We just didn't see infections going on in the community. At the end of that year, when we relaxed the NPIs, we saw an increase in activity. And when children came back during the fall of 2021, without distancing, but with masking, there was an increase in respiratory infections. When masks were taken away, it really made no difference. When they got to the summertime, there was no effect. But when they came back in the fall of 2022, there was a really large increase. So this is some really good evidence, I think, showing the effect of school district NPIs on community level respiratory infections. Also going to mention the mRNA vaccines, and by middle of March 2024, we saw across the globe over 13 billion doses of mRNA vaccines. We're starting to see this technology in other vaccines. So this is just a recent paper from a couple weeks ago looking at the efficacy in clinical trial of the mRNA influenza vaccine compared to the quadrivalent inactivated vaccine. And we're finding almost a 35% relative increase in effectiveness. So even though the funding has been pulled entirely nationally from mRNA vaccines, I think we have to accept the fact that these are going to be with us and are very effective tools because they can be updated very, very rapidly. I'm going to switch into some basics on respiratory pathogens here and just mention that within our Department of Family Medicine, the yellow lines here show the percent of our patients with a respiratory tract infection diagnosis. And we see a profound, well, first of all, we see a sawtooth implying the seasonality. And this is going from July through June. So the big peaks are in the middle of the winter. But during the pandemic, we saw a great drop and then kind of a resurgence thereafter. If we apply a 100-degree filter on that same data, we get something that actually is a pretty good marker for influenza. And again, during the pandemic, that disappeared and came back slowly. But you're asking the question, well, what happened to all of our family medicine patients? And this is what happened. The blue line shows us the trajectory of acute respiratory infections in family medicine with a drop during the pandemic and then coming back up thereafter. And in red, that shows UW urgent care. Family medicine visits dropped by 41% in the pre to post. So currently we're seeing a lot less respiratory infections in our clinics. Conversely, we're seeing a lot more acute respiratory infections in our urgent care settings. I don't know if that's access, if it's triage by our nurses, or if it's patient preference, but we're seeing a very, very different set of patients than we used to in primary care. When we look at infections within children, these are community-based children in our Orchard study. But what I want to point out here is that SARS-CoV-2 was being detected throughout the year. And now we're down into two big peaks per year with SARS-CoV-2. RSV in general is an October through April virus. Influenza A tends to be a virus we see in November, December, lasting into April. And influenza B tends to follow thereafter, but very strict seasonality. On the other hand, rhinovirus is around year-round, but really takes off when children come back to school after the summer. If we look at those kids who come into clinical practice, we find that respiratory tract infections are really a disease of childhood with a spillover into older people. But really see a large amount, and especially when we're looking at children age 3 to 4, almost 20%, 1 in 5 of our visits for those children have a respiratory infection diagnosis. When we look at the viruses we see in primary care, we see a dominance of influenza and rhinovirus. Keep in mind that this data largely excluded the period of SARS-CoV-2, which would have been a larger player for some time. On the other hand, if we look in long-term care, and keep in mind this is data from before the pandemic, we see a lot of influenza, human metapneumovirus, and RSV. So these three compromise almost 70%, and all three of these viruses will tend to send our long-term care residents into the emergency room and hospital. The last little bit I'm going to show you here is data from our orchard study being community and our clinic population being what we see as medical attendants. And I just want to point out that influenza A, influenza B, adenovirus, and the atypical such as mycoplasma, we see more of those in our clinic than we would expect based on what's circulating in the community. On the other hand, SARS-CoV-2 in children, rhinovirus, and the seasonal coronaviruses occur less commonly in our clinical practices. And the reason being is these tend to provide pretty mild infections and oftentimes without much in the way of fever. When we're talking about symptoms, I just want to point out a wonderful meta-analysis that just came out. And this was published at the end of October, but looking at the role of viral infections and cardiovascular disease. And this is a very large meta-analysis, but the takeaway here is that SARS-CoV-2 and influenza provide significant increased risks for cardiovascular disease and for stroke. So keep that in mind during this time of year. All right, so I'm going to switch over and talk about the specific viruses here and run through them. So RSV is transmitted respiratory droplets, surface and fomite contamination, but really think of it as coughing and sneezing within 3 or 4 feet or persisting on the surface for several hours. Typical symptoms in older children, adults are cough, sore throat, runny nose, a lot of nasal congestion. There can be wheezing, but respiratory distress is really common in young children. Incubation period 2 to 8 days. Symptoms usually 3 to 8 days after infection. And unfortunately, children and adults become infectious a couple days after the start of symptoms. And in infants and people with immunocompromise, this can continue on for up to 4 weeks. RSV is a really big cause of hospitalization in U.S. infants. Really, we look at 2 or 3% of young infants across the country historically would be hospitalized for RSV. In Wisconsin, our season, again, really October through April, and you'll see this again in terms of recommendations for vaccine and monoclonal antibody. So for prevention, we currently have 2 vaccines that can be given to adults. So we recommend the vaccine for everybody age 75 and older, and for high-risk individuals age 50 to 74. One of the vaccines is recommended during pregnancy, and it's the non-adjuvanted vaccine to be given 32 to 36 weeks, regardless of age. And we do this if we're not planning for the monoclonal antibody for the infant. I wanted to keep in mind that the vaccine effectiveness in real-world studies now has been about 68% in the first 3 months of the infant's life and dropping down to 57% in the first 6 months. You're going to see that the monoclonal antibodies work a whole lot better than this. So I stress monoclonal antibodies for all infants. Our treatment is pretty boring. It's supportive. We don't have any specific agents. We look at supplemental oxygen, bronchodilators, and symptomatic treatment. So when we talk about the monoclonal antibodies, and most of our data comes from nirsevimab, this is a recent study done in pediatrics, but looked at the real-world outcome and finding that nirsevimab effectiveness for lower respiratory tract disease was 87%, 98% against hospitalization, and 71% against PCR-confirmed RSV. So really, really high levels. The other thing I'll just mention is there is a second monoclonal antibody out there called Clesrev or Clesrovimab. Uh, and the one thing to keep in mind is the second one is recommended just for infants age 8 months and younger, regardless of weight. The Nirsevimab has a recommendation for high-risk children who are older, and we'll touch on that in just a little bit. The real-world effectiveness for the adult vaccines, 75% for RSV-associated hospitalization for patients age 60 through 75 years, and 76% for those over 75. The other thing to keep in mind, though, is this is a one-time vaccine, and we're seeing that the vaccine wanes over time. So in the same year, another study showed 69% effectiveness, dropping down to 48% in the second year, and we see progressive declines after that. We do not have a recommendation yet for revaccination for older individuals, but keep tuned for that. In Wisconsin, as of last week, we were only hitting 17% of our adults receiving RSV vaccine who would be considered eligible for the vaccine. So a lot of room to make up here. For infant protection, again, stress the maternal immunization, or even better, the Nirsevimab or Clesrovimab, the monoclonal antibodies. And I just really want to emphasize that first week of life or entering the RSV season. I'm going to just mention very quickly that we had the real world incredible effectiveness, and now we have the FDA investigating the monoclonal antibodies for what they feel might be adverse effects that have been shown not to exist. So just keep that in mind as well. The vaccine, this is the non-adjuvanted, can be provided to women anywhere from September 1st through January 31st in Wisconsin. The monoclonal antibodies can be provided to infants from October 1st through March. So just kind of keep that in mind. And again, my preference, if possible, would be to give the monoclonal antibody to all children. The dosage, just keep in mind that most children are going to be in this first class of 8 months of age or younger, and then it's going to be a weight-based recommendation, either 50 or 100 milligrams. For those older children with a high-risk indication, i.e. bronchopulmonary dysplasia, it would be 200 milligrams during that same period of time. So again, these are incredibly good preventive measures for RSV. I'm going to now turn to SARS-CoV-2. This is going to start getting boring because the transmission for all three of these are going to be about the same. Sneezing, coughing within 3 to 4 feet, highly infectious. Before we started, a lot of people were talking about how they acquire SARS-CoV-2 on an airplane. Right now, we're seeing cough, sore throat, runny nose, congestion. We're seeing less of the loss of smell and taste, but it tends to vary with the variant. Incubation period, 2 to 6 days. Symptoms are usually less than 7 days, but can continue for months in what we call the long COVID. About 10% of cases will get these chronic symptoms, and the transmission is most likely in the first 5 days or so. When we start looking at where we are, taking a look at the panel on the left shows us the deaths per 100,000 population, age adjusted in the United States, and we're seeing a really profound change between 2021 and 2025. We are watching this become an endemic virus instead of a pandemic virus with a much, much, much less pronounced death rate. If we look in Wisconsin, we're seeing typically two peaks. If you look at this panel on the right, the dashed line shows 2024-25 with a summer and a lesser winter peak. And right now, for some reason, we dropped out. I'm going to share again. Hopefully we got that back. I'm not sure what happened there, but we're seeing the similar pattern again with a summer peak occurring actually later, and then the start of a winter peak now, which I think is going to be less than our summer peak. If we look in the United States, just in terms of excess deaths in 2020, 21, and 22, we see an amazing thing that actually, if you add these three deviations up, they amount to about 1.1 million people. But we seem to, we have a lot of different evidence now that will indicate that this pandemic caused well over 1 million deaths in this country and really is very, very significant. Fortunately, we're getting back down to a much more normal level at this point in time. This is a study, again, just published a little bit ago, that looked at this recover cohort for COVID. And what I like about this is it follows longitudinally a lot of people and asking the question, what happens with your COVID? Do you get it again? Is there reinfection? And the bottom line is, even after all these years, about 10% of people go on to have long COVID. And there has been a lot of work looking at various subtypes, but the thing to keep in mind is the fatigue, the mental cloudiness, sometimes some mental health issues that are part of this long COVID. When we start looking at prevention and treatment, COVID-19 vaccines are still considered safe and effective. The Vaccine Integrity Project reviewed all this, found no emergent data to make us feel that the vaccines are unsafe, and they do reduce death, hospitalization, long COVID. A recent study looking at adolescents showed a 37% decrease risk of long COVID in adolescents with vaccine. This is annually updated because the virus keeps on changing. For post-infectious treatment, we have Paxlovid, Molnupiravir, and Remdesivir. The first two are oral agents. The Remdesivir is IV. The other things just to kind of keep in mind, and these are just conjecture right now, but azolastine, the nasal spray, 3 times a day for 56 days was associated with a pretty significant reduced risk of infection. And we're also seeing that prior rhinovirus infections are associated with a reduced risk of SARS infection. So we'll have to see what happens as time goes on. But the rhinovirus, in my mind, helps explain why we see this biannual peak of COVID. But again, the jury's out on this one, but I thought these were two really interesting recent studies. The COVID-19 vaccines are now considered by ACIP based on individual decision making. We recommend it for everybody 65 and older for individual based decision making, and for 6 through 64 months with a risk benefit or people who have an increased risk. But the bottom line is these vaccines are life-saving. They prevent hospitalization, they prevent illness, and they prevent long COVID. I'm just throwing out one of the newer mRNA vaccines called mNEXSpike is likely more effective than its cousin, the Spikevax. It's a reduced amount of mRNA that really focuses on the antigenic region of the spike protein. Okay, if you look at the ACIP recommendations, there have been moves to try and separate this vaccine from pregnancy. And this is a study that just came out from OB-GYN and looks at the outcomes of infants over 3 years after SARS-CoV-2 infection. The takeaway is there's a significant odds ratio of neurodevelopmental diagnoses in children born to women who were infected during pregnancy. It was greatest during the 3rd trimester and among male offspring. But so vaccination in pregnancy is still a recommendation from ACOG and AAFP. On the downside, we do a terrible job of vaccinating in Wisconsin. Only 9.8% of our Wisconsin residents are vaccinated, and we see a lot of disparity between non-Hispanic and Hispanic, and between white and black in this vaccine. So keep that in mind as you're seeing your patients. Okay, moving to influenza. I'm not even going to touch upon the transmission because it's the same. And this is real typical for fever, cough, sore throat, runny nose, and congestion. Incubation 1 to 3 days. I usually tell people if you're in with a patient and they cough and sneeze on you and you get to 72 hours without coming down with influenza, you're home free. Symptoms are typically 4 to 7 days, but really the worst on day 2 to 3 with high fever and cough, and can be infectious even before the start of symptoms. In Wisconsin, influenza tends to be a very seasonal virus, and if we look at isolations, they're really associated with temperature. Once we drop below freezing, we tend to see influenza come on. And once we come out from freezing, we tend to see influenza go away. So I really look at influenza as our prototypic winter virus. Okay, what to expect? Have a good friend, Ian Barr, who runs the World Health Organization influenza group down in Melbourne, Australia. And this is what he said about Australia. It's been another big year here for influenza. They saw the emergence of a variant, which is now called K. He suspects that this new virus is a pretty fit virus and may have quite a run in the Northern Hemisphere for our winter. It doesn't seem to be well covered by the 2025 vaccine component. And in Australia, they had quite a long season, so it's prolonged because of this variant. He also is worried about our low vaccine rates here and dysfunction within our CDC. But so what I'm predicting here is a moderate to severe outbreak of influenza with the usual timing in December or January. We're really seeing an upswing right about now after Thanksgiving. I also put up in the corner just the reminder that we're still worried about the crossover from the avian influenza into humans. There was a new virus, H5N5, that killed a gentleman in Washington State last month. So, prevention and treatment. Well, annual vaccine. We now have a trivalent vaccine because the pandemic and our masking and other activities drove one of the B viruses to extinction. We're still in a good period of time for vaccine if your patients haven't had it. We average about a 40% effectiveness for symptomatic influenza, but it's going to be higher than that for hospitalization and death. This is a very safe vaccine and required by UW Health for clinicians. If you're sick, stay home, delay medical visits if possible. If you're in the healthcare setting, wear a face mask. We find that oseltamivir, zanamivir, baloxavir, and peramivir are all effective, but they must be started very, very early in the period of time that you have virus. A lot of you will think of oseltamivir in children and think neuropsychiatric events. Well, a couple of things I want to point out here. First of all, the risk of ICU admission is really decreased for children hospitalized with influenza. Oseltamivir resulted in a 31% decline in ICU admission when it was used. If you threw out the children who received oseltamivir only on the day of ICU admission, it reduced the likelihood by 70%. So really keep that in mind for kids who are admitted. If we look at neuropsychiatric events in children and adolescents with influenza, if you look at oseltamivir treatment periods, there was a 47% reduction in neuropsychiatric events, and post-treatment period, it was a 55% reduction. So keep this in mind that these medications do not create neuropsychiatric events, they reduce them. In Wisconsin, we're lagging. We have a 25% coverage rate right now. Dane County is always kind of the top county, but there's a lot of disparity in who gets the vaccine. So really think about the vaccine and promote it. I'm going to spend the last couple of minutes talking about diagnosis and situational awareness. And diagnosis is really important. At UW Health, we basically have PCR or molecular assays either on a monoplex platform or a multiplex. I'm thinking particularly our influenza A, B, RSV, and COVID come together, or we can order those separately. The biggest problem in my mind is these require oftentimes shipment to a hospital. They require the laboratory time for processing as opposed to a rapid antigen test or a rapid molecular assay that can be done at the clinic or at the point of care. But that being said, the tools allow us to be more surgical in our diagnosis and treatment. I'm just going to mention that our team has done a lot of work with rapid testing, and we have the largest sample ever published in terms of looking at sensitivity and specificity with rapid tests. And I'm just going to point out that the older you get and the longer you're away from diagnosis or from onset, the less sensitive the tests become. On the other hand, if you have presence of influenza-like illness symptoms or a runny nose, the sensitivity for influenza goes up. If we look at specificity in rapid tests, none of the factors had any effect at all, simply because the specificity was very, very high, running 98 to 99%. But so if you're making a diagnosis or taking a sample, it's always better early on. And in the presence of older age, we tend to see lower levels of virus within nasal specimens. My quick summary for clinicians for these three include the route of transmission, the risk to healthcare personnel, prevention in healthcare settings, availability of vaccines, and having effective medications. And you can take a look across all three of these, influenza, RSV, and SARS-CoV-2, have a high risk of transmission to clinicians. They're all preventable by personal protective equipment, and all three have vaccines available at this point in time. When we talk about situation awareness, this is our ability to perceive, understand, and effectively respond to a situation. And this is where having an idea about what's going on can make a great deal of difference. So I like to toss out, when we look at respiratory symptoms, it's mostly respiratory viruses. But I also want you to think, especially in the summertime, of the particulate, the PM 2.5 micron. and wildfire smoke, because I've seen a lot of patients in the last 2 summers who are complaining about itchy eyes, sore throat, nasal congestion, and it's not respiratory virus, but it is Canadian wildfires. Our sources of Wisconsin data are many, and we are blessed with incredible resources. So the first one I'll mention is our State Lab of Hygiene that produces this time of year a weekly report and will provide current activity out there in terms of influenza, RSV, gastrointestinal viruses, and so on. The two panels here show our activity in terms of influenza and SARS-CoV-2, and then also a graphic showing other viruses out there. On the back side, it provides us a table of what's in circulation at this point in time. And they also provide us information on strep pharyngitis and the frequency of strep, which helps to set kind of a prior probability. Our Wisconsin Division of Public Health has moved from a PDF-based set of information to entirely web-based right now. And if you go to this website, we can identify this, or if you just Google Wisconsin Division of Public Health respiratory virus, it'll take you here. And this provides you a nice overview of, for example, low activity, stable, tells us about COVID-19, influenza, and RSV in terms of where we are. But it also down below provides us background on emergency departments, hospitalization, laboratory studies, deaths, wastewater, and influenza-like illness. And those are all click on and take you to additional resources. So this can be very helpful in knowing what's going on. Our State Lab of Hygiene is one of 4 centers of excellence in the United States for wastewater monitoring in Wisconsin. And we can have a very, very good idea of what's going on with COVID-19 by looking at sewage. When people have COVID-19, they shed a lot of virus in the stool, and this is easily picked up by wastewater surveillance and PCR testing. And so this allows us to have kind of advanced warning as things are going up. So I looked at this morning, and in fact, COVID-19 is starting to increase again in Wisconsin. We can also drill down to individual communities on this website. Within our Department of Family Medicine, at Belleville, Northeast, Oregon, Verona, and Wingra, we actually do direct surveillance of individuals coming in with acute respiratory infection. And this provides us a good idea of what we're seeing in terms of our clinical population. This year, we've also added in Union Corners urgent care. And we've done that just because there's been the shift in ARI patients from primary care to urgent care. And we're hoping that will help with the numbers of specimens we're getting in. Finally, for those of us in Dane County, we have a Dane County dashboard that tells us very much or very similar information to our Department of Health Services Wisconsin dashboard, but this is really focused just on our county and will tell us about what's going on. This is now a couple weeks old, but at that time, our respiratory illnesses were minimal and stable. If you click on, or if you look at the first URL, you can get on their email list for this. Or the second is the email list. The first will be just taking you to the dashboard itself. But this is really helpful for that situational awareness. Finally, for our clinicians, our Bureau of Communicable Diseases provides an update of respiratory illness prevention communication for clinicians. And again, this is a great resource that provides you toolkits for talking to your patients and also for considering what to do with yourself if you become ill. UW Health has really stringent guidelines. Uh, we still require testing if you're experiencing symptoms. And as of November 10th, we don't have to do testing to go back to work, but there's guidelines. So, for example, for mild to moderate illness, you can return to work on day number 6. And this is after you have 24 hours fever-free without use of acetaminophen or ibuprofen. But you have to come back through 10 days with a N95 mask. For severe illness or immunocompromise, we're looking at staying out for 11 days or 10 days, returning on the 11th day. So my final thoughts, I'm just going to jump down to the generous accommodations for trainees and students during acute illness periods. And it should be acceptable to mask, distance, and stay home. And abundance grace for yourself and your colleagues. Again, it's appropriate to mask, distance, and stay home when you're ill. So pandemic provided us with really wonderful new tools and techniques. And I'm thinking here are masking, our distancing, our mRNA vaccines, and wonderful diagnostic tests. Situational awareness through surveillance will really help us to improve our approach. Rapid diagnostic tests, be they antigen or molecular, can help and transform care. Always use antibiotics sparingly, antivirals appropriately. And finally, our use of prevention is always better than treatment. And with that, I think that's everything I have. I'm open for any questions you might have, and I'll thank you for your attention.